Coming? Can you make it full screen? I'm not coming with that. Can you make it full screen? I'm not coming with that. Yes, you can do the. Now is it okay? Yes. Now it's okay, no? Okay. Friends, we are going in for a revision lecture of diphtheria. I will be running through the slides because I expect that you have revised already diphtheria. I want you to remember that diphtheria was a condition which was rampant in India earlier. Now, since the year 2016 onwards, we are having a resurgence of diphtheria, including in Telangana. And this resurgence of diphtheria is being seen in people who are in the adolescent age groups. So there has been a change, a shift in the age group which is involved, and this is something which is classical of any vaccine preventable disease. We start vaccinating individuals who are vulnerable. The vulnerable population uh, gets immune. However, the people who were earlier considered to be not vulnerable, suddenly we find that they become vulnerable to the disease. So it is an interesting epidemiological shift which takes place. Okay, so diphtheria is caused by Corynebacterium diphtheria. We are well aware of that. It's a vaccine preventable disease, and we know that Corynebacterium diphtheria is a gram-positive, non-motile, non-sporing organism, produces a powerful exotoxin. We have the Gravis, Mitis, and Intermedius and Belfanti strains which are there. Betaphage can convert a non-toxigenic into toxigenic. We are aware of all these things. We have passed our microbiology, so you're masters in this. Okay. We have cases which are clinical and subclinical, and carriers. Now, carriers are very, very important because they are the ones who are possibly transmitting the disease. So you have temporary carriers, chronic carriers, nasal carriers, throat carriers, and the maximum are the nasal carriers. The important thing to remember that immunization does not prevent a carrier state. That is the problem which we are facing. That immunization is preventing the disease but not preventing the carrier state. Same story is going to possibly take place in COVID, and that will be the whole issue which will be there, because what the studies which have been done on COVID show that a large number, the severe cases are prevented, the moderate and severe cases are prevented. You may still continue to get mild cases, and you may still continue to have people carrying the disease. Of course, too early in the day to to speak about what the COVID vaccine is going to produce, what are the results going to be produced. As you're aware, there are two different types of COVID vaccines, two major types. One is the mRNA vaccine, which is basically a messenger RNA which will trigger out various immunological reactions in the body. And second is the classical vaccines, where we're using portions of the virus to trigger an immunological response. Various types of the vaccines are coming in the second category also. So we'll not go into the details today. But it's important to remember that many a time these immunological responses which are there do not prevent the patient from getting the infection, and they result in patients having an immune response. So the patient gets the infection, the immunity of the body fights this particular infection, and hence the patient does not get a disease, a clinical disease. Very important to remember. It is not that you have a barrier which is there and the patient doesn't get the infection. So, okay, let's go further. Now, the infected material is nasopharyngeal secretions, fomites, infected dust, discharges from skin lesions. You're well aware of that. Why is it so? Because you'll see as we tell about the disease, basically you have different types of diphtheria. So different types of diphtheria which are there can be in nasopharyngeal secretions or in discharges, and you can have skin lesions. The skin lesions also can ooze out diphtheria. Period of infectivity is 14 to 28 days, and carriers till 2 cultures 24 hours apart are negative. We'll have to look at the host factors. As I mentioned in the beginning of the class, is mainly in children. That was what was prevalent earlier, mainly in children. Today we are having a large number of diphtheria or diphtheria-like illness which is occurring in adolescents and in adults. Many of these are not being labeled as diphtheria because they are unable to get a culture response from the samples which are taken. What are these and whether these are actually diphtheria is for a discussion for another day. Males and females are equally affected. In the inapparent infection also confers immunity, as in most infections. Herd immunity, what is expected is 70% is necessary to prevent spread. Now, again, we keep harping about herd immunity in COVID. Herd immunity, herd immunity, herd immunity. We're looking at infections or immune responses which we have seen by various sample surveys which have been done in our country show an immune response of about 10 to 25%. So we're not looking at huge. We require a herd immunity of approximately 70% so that the transmission does not take place even in COVID. And so there is no, I keep repeating this, there is no disease which has been controlled by herd immunity due to natural spread of the disease. People keep on saying COVID is spreading so much, so now we'll get herd immunity. And I had an interview with the Times of India in which they were asking me the same question which is there. They said, why don't we do immunological studies? And if the immunity has risen till the herd immunity, we don't require vaccination. No, there is no disease where natural immunity has resulted in herd immunity. Natural disease has never resulted in a herd immunity. Why do many of the diseases disappear suddenly? The reason is that the virus or the bacteria becomes less virulent. The body's response becomes stronger. So these are things which keep changing, or the treatment guidelines improve. So all these things will result in the natural history of the disease changing. Environmental factors are more common in winters, mainly spread by droplet infection, and sometimes you've got cutaneous lesions. Fomites is rarely in all respiratory diseases. Please remember that they keep on talking about fomites. Fomites is very rare. Rarely does fomites transmit the disease. We're talking about fomites when we talk about in the hospital setting, where we have a large amount of droplets with being possibly coming on bed sheets and on tables, etc., all these areas, and these being taken up when during dusting or various other things. They are taken up and spread by people for doing the dusting, as well as due to air circulation, due to air conditioning. So these dust particles from the fomites may then transmit disease. Otherwise, respiratory disease per se is transmitted by droplet infection mainly. Incubation period is 2 to 6 days. And diphtheria exotoxin causes formation of a false membrane over tonsils, pharynx, or larynx with well defined edges and cannot be wiped away. Important because today's diphtheria like illness which is there is also causing a membrane, but this membrane, when you wipe it, you don't have a bleed like there which takes place in diphtheria. You have a membrane forming, though it is negative for streptococcus, where again you can have a sort of a membrane forming. So it's a confusing epidemiological situation which is taking place. In our fever hospital, we have our one of our postgraduates is now posted there. She keeps telling me that a large number of cases of diphtheria-like illness coming in every day, and it is causing complications similar to diphtheria. Marked congestion or edema, enlargement of local lymph nodes, and signs and symptoms of toxemia. So basically, the onset is sudden. Then you have temperatures of 102 degrees Fahrenheit, malaise, sore throat, feeling of tiredness, and initially the sore throat is not very marked, but later on, as the membrane grows, you will find that the hoarseness of breath and the hoarseness of voice, and there is this sore throat. The membrane formation is due to necrosis of the epithelial tissues, serofibrinous material liberated from which forms a greenish white membrane. It is very, very classical. Once you see it, you'll never forget. Edges are curled and or separated from the underlying mucous membrane, and as I said, it bleeds on peeling, and there is an increased toxin absorption. Usually, one tonsil is involved and soon spreads to the opposite side. Patient discovered late shows extension from the tonsil to the fauces or to the pharynx. So in mixed infections, it's very common to have mixed infections with streptococci, and in that you can land up with septic diphtheria, which is high-grade fever, atypical appearance of membrane, and greater inflammation in surrounding structures. So what is coming now, that is you're getting an atypical presentation which is there. You're having this membrane which is not typical of diphtheria, but you're neither getting a streptococcal positive nor are you getting a diphtheria positive. So it's a little bit confusing. So the manifestations, as we said, local inflammatory membrane, inflammation, membrane formation, toxemia. And we have different forms of diphtheria, which I'll just discuss: tonsillar, pharyngeal, laryngeal, anterior nasal, other forms. The tonsillar one basically is a thin membrane on the tonsils, more often identified on two tonsils as grayish yellow membrane. A narrow area of redness surrounds the membrane, and there's tender and enlarged submandibular lymph nodes. Fauces is normal. So this is the membrane over the fauces, which is there. You can see this particular membrane which is there over the tonsils. And as far as pharyngeal diphtheria is concerned, there's further spreads to the uvula, to the anterior portion up to the teeth, and posterior pillar to nasopharynx. So because of this, there is a foul smell or necrotic. When the necrotic material is present, there's a foul smell which is called the fetor oris. When bleeding occurs, the membrane becomes foul black mass of tissue, and throat is congested. The swelling of the tissues in the front of the neck as well as the lymph nodes form an area which makes you feel as if this person has got a swelling of the neck called bull neck. Patient is drowsy, pale and tired. So there's a bull neck. You can see the filling of the neck as well as the sides, the front as well as side of the neck. There's a bull neck which is formation. The laryngotracheal diphtheria is generally preceded by the pharyngeal tonsillar disease, cough, hoarseness of voice. But remember that the moment anything comes to the larynx, laryngitis or laryngotracheal, it's dangerous because it can result in difficulty in breathing and can further go down the bronchial tree and cause respiratory distress. Laryngeal, as we're talking about laryngeal one, that is most common due to mitis and may spread to the trachea, bronchi, and bronchioles. Basically, the symptoms are due to the obstruction, that is huskiness of voice, croupy cough, inspiratory distress, and stridor. And the person may go into asphyxia. You may require to do a tracheostomy. Anterior nasal, basically you get only mainly a discharge which is thin and blood stained, and maybe with the superadded infection it may be thick and mucopurulent. There's a thin yellowish membrane in the nasal cavity which is there. Please remember there are non-respiratory forms of diphtheria also which can affect the skin, eye, intestines, genitourinary tract, and diphtheritic endocarditis, which is a complication. So, skin, it is common in the tropics and mostly in the fingers and back of the hands, which basically is spread from the fauces because one, if is trying to clear the fauces with the finger. Punched out ulcers are there. Eyes, secondary to anterior nasal one, spreads to the nasolacrimal duct, manifests as a conjunctival diphtheria. Rarely you get panophthalmitis. This is the skin sore which occurs. Intestines, urogenital tract, and diphtheritic endocarditis are also complications of diphtheria. In intestines, you can have bloody diarrhea and dysphagia. In urogenital one, you can have vulva and vagina involved, or the coronal sulcus and glands being involved. And in endocarditis, you have a very high fatality rate. So complications of diphtheria are get me a glass of water. The complications of diphtheria, nasopharyngeal, laryngeal, and myocarditis. So these complications are basically due to the complications due to the toxin. The nasal, tonsillar, and pharyngeal diphtheria are you don't normally get complications from them. Other ones are otitis media, albuminuria, and peritonsillar abscess. So as we were mentioning, the complications: myocarditis, peripheral neuritis, paralysis of palate, diaphragm, lower extremities, and extraauricular muscles, endocarditis, osteomyelitis, arthritis, and respiratory obstruction. So let's just discuss the various complications. Now, what happens in early myocarditis? The time of occurrence is between 3 to 7 days. Peripheral changes, which include pallor, rapid and steady pulse, collapse of BP, vomiting, and upper abdominal pain are the ominous signs which are there. Upper abdominal pain, what we're looking at is basically myocarditis, which is resulting in a referred pain to the abdomen. So the pain basically is because of myocarditis, but it is resulting in vomiting. These are basically signs which you must be careful about. Heart sounds and heart rhythm are normal in this myocarditis. Shock due to toxins affecting the adrenals and vas deferens also can occur. So one has to be careful in myocarditis. The patient's fatality is high in myocarditis cases, and the patient survives. There are signs of cardiac involvement. Late myocarditis, the time of onset is 5 to 14 days. Patient has pallor, weak, slow and steady pulse. S1 is absent and S2 is soft. And so it's a galloping rhythm which is there, and heart rate is irregular. Again, referred pain to the abdomen. So many a time we get patients with referred pain to the abdomen. We must do a cardiac examination. Always remember that. Always, whenever, especially when there is upper abdominal pain or even backache for that matter, please remember to, if there are associated symptoms, please do a cardiac examination. Peripheral and splanchnic vasculature dilation can take place. Apex, because of the myocarditis, because of enlargement of the heart, you may have the apex shifted outwards and downwards. ECG changes, T wave is inverted or flattened, and you have a PR or QT interval lengthening. Usually patient recovers without any damage, or if there's only ECG changes and we don't have moderate myocarditis. So then the various paralysis which can take place of the palate, which is most common, sets in on the 3rd week and lasts for about 2 weeks. If you ask the person to pronounce certain alphabets, he is unable, difficult for him to do it because there's palsy of the palate. Patient is unable to direct his lips and purse his lips. So eyes, there's blurred vision, paralysis of accommodation, again persists for about a week. Convergent squint may take place because of the lateral rectus paralysis. Pharyngeal paralysis again will result in difficulty in swallowing. Saliva will get collected in the back of the throat, so a person will get choked. If larynx is also involved, the aspiration may go into the bronchial tree. Laryngeal paralysis, loss of voice, ineffective cough is present. If there is paralysis of the limbs, most commonly involved part is the dorsiflexors. So, how do we diagnose diphtheria? Diphtheria, basically, one has to diagnose from clinical diagnosis, and you can have supportive lab diagnosis. So, in the clinical diagnosis, basically, you're looking for the membrane. So, membrane can be there in faucial. In pharyngeal, you'll look for the bull neck or the lymph nodes. In laryngeal, you'll do a laryngoscopic examination for the membrane and look for, if your person has got croppy cough. Nasal one, again, see the terminal, see the septum, and if there is a diphtheritic paralysis, one has to look for that and look for various other signs and differentiate between various other paralytic diseases like polio or Guillain-Barré syndrome. Swabs to be taken from the throat, nose, larynx, skin, and tracheal exudates. And the culture medium which we use is low-flow serum slope. And we can do animal inoculation also, but rarely done. When you do a smear, you're staining it by the Albert stains, and then you can do serological tests. All theoretical. You hardly do all these tests which I'm going to tell you. But anyhow, you must know it for the point of view of exam. The virulence tests which are possible to test toxigenicity in vivo and vitro are guinea pig inoculation, and in vitro is by the LX gel test and the tissue culture tests, which are rarely done. Again, something which comes for the exam but hardly ever done now is the Schick test. But just for the sake of completion, and because it is asked in the exam, I might as well complete this. That is a quantitative test which because of circulating antitoxin. Reliable test for susceptibility used in investigation of outbreaks, and basically it tests for the antitoxin and hypersensitivity to diphtheria toxin. So what we do is 0.2 ml of the fluid containing measured doses of DT is injected intradermally into patient's left forearm. Similar amount of heat inactivated toxin is injected into the other arm. So what will be the positive reaction? You'll get a red circumscribed flush, which is seen in the test arm of 10 to 50 millimeters. If you have a pseudo positive, you'll get red flush in the other arm also. Peak day is 4th to 7th day, and so one has to look for a pseudo positive or a negative reaction which is there, and combined reaction is test arm is true positive and the other arm is very less reaction which is there. Allergy, you must look for people who are allergic to this. So what we do is prevention and control. Basically, we are looking at standard guidelines of control, that is early detection, isolation, treatment, notification, look at the attendance, the contacts, and take some epidemic measures. High index of suspicion should be there based on clinical features and bacteriological investigation. And clinical examination, you do Albert stain, low flows, serum slope. You can do a fluorescent antibody test. Toxigenicity can be checked with LX test or susceptibility by Schick test. And again, I will not go to this thing. Basically, nasal diphtheria, you should also look in the differential diagnosis whether there's a foreign body in the nose, especially in children. Many a time they don't mention that they put something in their nose and you find a foreign body in the nose. So please do a specular examination and check for that. A normal rhinorrhea due to various viral infections, or congenital syphilis can also give similar picture for as nasal diphtheria. In fossil diphtheria, you can have a differential diagnosis of streptococcal tonsillitis. Types of it, you can even have viral tonsillitis or herpetic tonsillitis or thrush. Thrush is the diagnosis one has to look at because you can get confused. Infectious mononucleosis also gives some sort of a fossil diphtheria picture sometimes. Laryngeal, you should differentiate from laryngotracheobronchitis, or whether any abscess, whether it is retropharyngeal or a peritonsillar abscess, or whether there is bronchopneumonia. So all these things, please differentiate. And principles of treatment is basically isolation and neutralization of the toxin with an antitoxin. Antibiotics to eliminate the bacteria, and supportive and symptomatic treatment and management of complications. Isolation is basically there because you don't want the person to be spreading the disease to other people. So all cases should be isolated for at least 14 days or until proved free of infection. At least 2 consecutive samples you will discharge the person only after taking 2 consecutive samples from the site and find that to be negative. Patient to wear a mask and dispose sputum after disinfection. Antitoxins interfere with the action of the toxin and modifies the attack. So that is very important. It's good to give. Administered as soon as infection with diphtheria is suspected. Can be given IM or IV after testing sensitivity to antitoxin. And after administration of antitoxin, is observed closely for anticipated reactions which are there. These are the doses which are there. Again, antitoxin is hardly given nowadays. It's got its own inherent problems which are there, and as I said, unless and until you diagnose a case of diphtheria, definite diagnosis of diphtheria, you will not give the antitoxin because these antitoxins would be produced from various horse sera or various other this thing, and you can have reactions which can take place, alarming reactions which can take place, and we have taught you that when we were talking about antitoxins and in epidemiology. Antibiotics which are there should be basically given to terminate toxin production, to limit proliferation of bacteria, to prevent spread of the organism to contacts, and to prevent development to the carrier state. Penicillins continue to be the mainstay of treatment, that is procaine penicillin, oral penicillins, or erythromycin. These are the mainstays, still continue to be mainstays of treatment. If they are resistant, then we can think of various other um, antibiotics. Clinical infection does not result in immunity. The attack should be followed by active immunization. The supportive therapy is to give the person bed rest, avoid sudden exertion, observe the patient. Mainly we are concerned with, see, when you look at the complications, the main concern is myocarditis, endocarditis, myocarditis. So we can keep monitoring the patient as far as the ECG is concerned and the rhythm of the heart is concerned. Give the person antibiotics, sedatives, and observe. Antibiotics you're already giving. Give a good high calorie diet, give supportive therapy. If the person is suffering from toxemia and myocarditis, ensure you give the adequate amount of fluids, and then move on to steroids. And if it's going into failure, then you're talking about digitizing the patient or various other drugs which are available today. Paralysis which is there, one has to give supportive therapy. If there is a paralysis which is there, many a time the paralysis disappears on its own, but we need to give supportive therapy for the time being. For when the palate or the pharynx is involved, you may require an nasogastric tube. You may require suction of the mucus. For respiratory obstruction, you may like to give an oxygen therapy or do a tracheostomy. So, what about contacts? Contacts is based on the immunity status of the person. If the primary immunization has been done, or booster has been given, or has been given within 2 years, then you don't really require to give any further treatment, further boosting. If it is greater than 2 years, then you require to give a booster. In non-immunized close contacts, it is controversial to give antitoxin. As I said, antitoxin is nowadays hardly utilized. So it's controversial, but it can be thought of if you're. Better is to give prophylactic antibiotics and put the person on active immunization. More important than all that is all close contacts should be placed under medical supervision and examined daily for evidence of diphtheria for at least 1 week after exposure. 14 days is what we keep on telling. 14 days we are mentioning even for COVID, and 14 days we are mentioning for diphtheria also. 14 days is the time that is the maximum incubation period of the disease. So we must try and observe for 14. If you can't observe the person for 14 days, at least for 7 days, the contacts require to be observed whether they are developing any symptoms. The carrier state which is there should be treated. I mean, you treat the patient with various penicillin derivatives which are there. You can use erythromycin and give the patient the carriers this particular 10-day course of oral erythromycin. Prognosis depends on the extent of the membrane, ability of the organism to produce toxin, and immunity status of the patient. If the membrane is limited to the nostrils, toxicity is generally negligible. But if the membrane presents on both tonsils, then the patient is likely to develop a paralysis of the palate. If the membrane extends beyond tonsils involving the palate and nasopharynx, patient may suffer from any or all of the severe complications. So one has to be careful. The moment it goes beyond the tonsils, you're starting to get the pharyngitis and laryngitis. Laryngitis is a dangerous complication. If there is hemorrhage, the prognosis becomes grave. So you have to keep monitoring the levels of if there's any bleeding. Diphthetic paralysis is temporary condition and recovers. As I mentioned, it's a temporary condition and you may recover completely. What else are the preventive strategies? 4 key strategies which are there. Primary prevention by ensuring high population immunity that we are doing by giving vaccination. Strengthen the surveillance system. An early diagnosis and high quality of case management should be followed. And rapid investigation and management of close contacts. So, you're doing immunization, you're doing health education, you got vaccines, the list of vaccines are put over there, DPT with P which is wholesale, or DTP with P which is acellular, and the adult DT and the child DT. The other vaccines which are there with various additives which are there, those are also single vaccines can be used. But nowadays we are not using single vaccines, we are using DPT. The important thing to remember is today we are shifting from giving TT to DT. What is happening is that earlier mothers were given TT during pregnancy. Today we are shifting from TT to DT. So please remember that. Now we'll be giving to pregnant ladies 2 doses of DT. One in the first trimester, one in the second trimester. So TT is going, DT is coming in. The reason is that we want to give immunity to the newborn, and also because it has been found that immunogenicity improves when you do this particular way. DPT vaccine, as you know, is a plain. There are 2 types, plain and adsorbed one. Mostly we are using the adsorbed with a mineral carrier. It can be stored in refrigerator at the normal temperatures of the refrigerator, 2.2 to 8 degrees, and temperature extremes may adversely affect the use, the resuspensibility of the vaccine. So we'll talk about suspensions and all that in due course. So basically, you do a shake test. You shake the fluid of the vaccine and check. So if you get particles, you get this thing, just throw out that vial. So this is the various ways of checking the sediment test. If you get sediments, generally the thumb rule is if there are sediments, please throw out that particular vaccine. Getting a control, getting it done is very rare in our country. You just look for sediment present, throw it out. The vaccine is allowed to freeze. The link between the antigen and the adsorbent gels gets broken, and it comes out in lumps and becomes heavier. So please remember, this vaccine is not to be frozen, So when do we give it? You are aware of the regimen which is there: 6 weeks, 10 weeks, 14 weeks, booster at 18, 24 weeks, again a booster at school going, the 5 to 6 years, and additional booster at 10 years. And with immunization, standard swelling, redness may occur. Sometimes you have difficulty in walking, and this will persist for about 24 to 72 hours. After that, it goes off on its own. Sometimes if a nodule or an abscess is formed, then you'll have to take some action. Systematically, we find fever, lassitude, anorexia, and excessive crying due to that, because of all these things, excessive crying of the child, and sometimes you get convulsions. So basically you have fever, pain, redness, which is common. Rarely you get very high fever, seizures or convulsions, collapse, very rare. What are the contraindications? Allergy or anaphylactic reaction is an absolute contraindication. Relative contraindication is hypotonic or hyporesponsive episodes which are taking place. And deferred is when should be considered in children with progressive neurological condition, including seizures. Then you defer it for some time. If immunization, um, so let's further go. All these things are the various types of vaccine. Please read up. It's not really important because basically now we're talking about only DPT, but it's worthwhile reading up about formal toxoids and adsorbed toxoids. The adsorbed portion which is there gives a boost to the vaccination. Passive immunization also, as I said, can cause reactions because we're using horse serum, and hence the body can react or will react with the next injection whenever it takes place. That's all that I have for you. Please read up about diphtheria. Can come because of the resurgence of diphtheria, and so please ensure that you read up about the disease. Yeah. Yeah, Deepika, how do you this one? No, what? How do you find out what Pavan was saying?
So now people are there for your live session.
Not here.
It's coming. It's over. Five watching.
So the five who are watching, please remember that the moment you come back.
Once was the top shot.
So the five who are watching, please remember that the moment you come back, we're going to have the exams, and so please get ready for your exams, for your um, final pre-final exams. Yeah. Okay. All the best. Bye. Final pre-final exams. Yeah. Okay. All the best.